Most people over 60 are told the same thing about hip pain. Rest it. Take something for the inflammation. And if it does not settle down, we can talk about an injection. It sounds sensible. It sounds safe. But here is what nobody tells you. Rest and an injection alone do not protect your ability to get out of a car without planning it first. Large population studies put the lifetime risk of developing symptomatic hip arthritis at roughly 1 in 4, and orthopedic clinics see the same pattern every single day. The people who do best are almost never the ones who rested the longest. So today I am going to walk you through 5 movements that together make up a 90-second routine, the kind of routine surgeons and physical therapists hand out long before anyone reaches for a needle. And I am going to give you the one piece of information that a 12-minute appointment almost never has time to cover. The number 1 movement on this list is something almost nobody talks about, and it is the only one on the list that asks you not to move at all. Stay with me until the end, because that one can change how you approach the next 10 years. Here is the honest problem. The average appointment for hip pain runs about 12 minutes. In that time, your doctor has to hear your history, examine you, look at an image, and make a decision. Teaching you a movement pattern properly takes longer than that on its own. So the appointment gives you the thing that fits inside 12 minutes. A prescription, an image, or a referral you may wait months to reach. I am not here to sell you a supplement or scare you into a course. This channel exists to give you the science a 12-minute appointment never has time to cover. Nothing on this list costs money. Nothing on this list needs equipment you do not already own. Because the real stake here is not pain. The real stake is whether you can rise from the toilet without pushing off the sink, carry a bag of groceries up 3 steps, and sleep through the night on your own side of the bed. That is independence, and a great deal of it is decided at the hip. So before we go further, tell me in the comments how old you are and what town you are in. And tell me which hip it is, the left or the right. Now please do not skip this next part. It is the key to everything that follows. Most hip pain after 60 is not simply a wear and tear problem, it is a control problem. On the outside of your hip sits a bony bump called the greater trochanter. 2 muscles, the gluteus medius and the gluteus minimus, anchor onto that bump and hold your pelvis level every single time you stand on one leg. Think of a flagpole standing out in a field. The pole itself is strong, but it does not stay upright on its own. Thin steel guy wires run down to the ground and hold it steady against the wind. Your side hip muscles are those guy wires. When they go slack, the pole begins to sway, and every part of it grinds where it never used to. Your pelvis drops a fraction of an inch with every step you take, and that fraction is where the pain lives. If this is already making sense to you, tap the like button so more seniors can find it. That is the only thing I will ask you for in this video. Number 5 is the counter hip hinge. Not a squat, not a toe touch, a hinge. Years of sitting teach your body one bad habit above all others. You learn to bend at the lower back instead of folding at the hip. The joint stops traveling through the range it was built for. Think of a garden gate that has been left half open for a decade. The hinge does not stiffen because it was used too much. It stiffens because it was never taken through its full swing. Movement retraining research in older adults keeps showing the same thing. Restore the hinge, and the load moves off the spine and back onto the muscles designed to carry it. Here is how you do it. Stand at your kitchen counter with your feet about hip-width apart and your hands resting lightly on the edge. Soften your knees, then push your backside straight back, as if you were closing a car door with it. Your chest comes forward, your back stays flat, and you should feel a stretch behind your thighs. Go back until you feel that stretch, then squeeze your backside and stand tall again. 8 slow repetitions takes about 15 seconds, and I want that twice a day. The most common mistake is squatting down instead of pushing back, so if your knees travel forward, you are doing a squat. If standing free is uncomfortable, hold the back of a sturdy dining chair placed against a wall. Keep your weight in your heels and your eyes forward, not down. Stop if you feel sharp pain in the groin or the front of the hip. Sharp pain means stop, not push through. Pair the hinge with the sit to stand you will meet at number 3. The hinge teaches the pattern, and the sit to stand adds the strength. Doing one without the other is like learning the shape of a lock without ever cutting the key. But the hinge only works the back of your hip. It does nothing at all for the front, and the front is where most of the damage from sitting actually lives. That is what number 4 fixes. Put your hand on the outside of your hip right now, just below your belt line. Press in and feel that bony bump. That is where number 1 does its work, and we are coming back to it. Number 4 is the standing hip flexor lean. It is a stretch, but not the kind most people do. At the front of your hip sits a thick muscle called the psoas, and it runs from your lower spine down to your thigh bone. Every hour you spend sitting, that muscle sits in a shortened position. Over years, it simply stops asking to be long. Go back to the flagpole for a moment. If one guy wire is cranked too tight, the pole does not stand straight, it leans. A tight front hip tips your pelvis forward and pinches the joint at the very front with every step you take. Gait studies in older adults show the same finding again and again. The stride shortens at the back leg first, and a short back leg is very often a tight front hip. So here is the lean. Stand facing your counter with both hands on it. Step your right foot back about 1.5 feet, keeping that back heel down if you can. Now tuck your tailbone under, as if you were tucking in a shirt at the back. Squeeze the buttock on the back leg, and lean your whole body forward a few inches. Hold for 10 seconds while breathing normally, then switch sides for another 10. 20 seconds in total, twice a day, and never bounce. The mistake almost everyone makes is arching the lower back instead of tucking the tailbone, which feels like a stretch, but is really your spine bending. Keep both hands on the counter the whole time. If you have had a hip replacement, ask your surgeon which positions are safe for you before you try this. And stop straight away if you feel a sharp pinch at the front of the hip rather than a broad stretch at the top of the thigh. Pair this with number 5 and do the lean first. A joint that cannot straighten cannot hinge properly. Length first, then pattern, but length alone will not hold. A stretched muscle drifts back to short unless something stronger holds the new position. That is exactly what number 3 builds. Number 3 is the sit to stand, done slowly and done properly. This is the most honest test of hip strength you can run in your own kitchen. Standing up from a chair is not really a leg exercise. It is a hip exercise. Your gluteus maximus, the largest muscle in your body, does most of the lifting. Think of the hydraulic lift on the back of a delivery truck. When the fluid runs low, the platform does not stop working all at once. It just needs a shove, and then a bigger shove, and then 2 people. There is a clinical measure called the 30-second chair stand test, used in fall prevention programs, including the one run by the Centers for Disease Control. It counts how many times you can rise from a chair in 30 seconds, and it tells us a great deal about the years ahead. Here is the version I want from you. Sit in a firm dining chair with your feet flat and pulled slightly behind your knees. Cross your arms over your chest if you can, or rest your fingertips on the counter if you cannot. Lean your nose forward over your toes, then drive through your heels and stand all the way tall. Now the part everyone skips. Lower yourself back down over a slow count of 3 instead of dropping the last few inches. 5 repetitions takes about 20 seconds, and I want 2 rounds a day. Put the chair against a wall so it cannot slide. If you cannot rise without your hands, use one hand on the counter rather than 2, and take that hand away as you get stronger. Stop if you get sharp pain at the front of the knee. And if you feel lightheaded when you stand, sit back down, because that is blood pressure and not weakness. If you take blood pressure medication, talk to your doctor before adding repeated standing work. Pair this with the hinge from number 5. Do the hinge first as a rehearsal, then the sit to stand as the real thing. The pattern comes first, the power comes second. But standing up from a chair only trains the first half of your hips range. The last part, where your leg travels behind your body, is the part you almost never reach. That is what number 2 restores. Quick question before we go on. When you sleep on your side, do you put a pillow between your knees? Hold that thought because it comes straight back at number 1. Number 2 is the glute bridge, done on the floor or on a firm bed, whichever you can reach safely. When you walk, your leg has to travel behind your body before the next step begins. That final push comes from your buttock, and if it does not arrive, your lower back quietly takes the job instead. Picture a drawbridge over a moat. The chains lift it, but if the chains hang slack, the whole weight lands on the stone hinge at the bottom. Your lower back is that stone hinge, and it is why so much hip trouble gets mistaken for back trouble. Muscle activity studies show the bridge produces some of the highest buttock activation of any floor exercise. It is also one of the few that puts almost no compression through the hip joint itself. Lie on your back with your knees bent and your feet flat, heels directly under your knees. Rest your arms by your sides with your palms down. Press through your heels and lift your hips 2 to 4 inches to begin with, not as high as you possibly can. Squeeze your buttocks hard for 2 full seconds at the top. Lower slowly, and touch down without resting there. 8 repetitions takes about 20 seconds, once or twice a day, and you add height only when the low version feels easy. If getting to the floor is not safe for you, do this on a firm bed, never on a soft mattress, because your heels sink in and you lose the push entirely. If it cramps in the back of your thigh, your feet are too far away, so slide them closer. And if you feel it in your lower back, you are lifting too high, so cut the height in half. Pair the bridge with number 4, the hip flexor lean, and always stretch before you bridge. A hip that cannot straighten cannot be extended behind you. You are asking a door to open while the doorstop is still down. So that is 4 movements, and every one of them asks your hip to move. Every one of them is worth doing. But not one of them does the single thing the outside of your hip is actually crying out for, which is to hold still under load. Number 1 is the isometric hip abduction hold. That word isometric simply means you push, but nothing moves. Come back to that bony bump on the outside of your hip, the greater trochanter. 2 tendons pass over it like a rope running across the edge of a rock. When your pelvis drops toward one side, that rope gets pressed down onto the rock. And it is the pressing, not the movement, that irritates it. This is why pain on the outside of the hip gets worse when you cross your legs, when you sleep on your side without a pillow between your knees, and when you stand with all your weight hanging on one hip while you wash the dishes. Every one of those positions squashes the tendon against the bone. Now here is what makes a held contraction different. When you push without moving, you load the tendon without dragging it across the bump. And a sustained contraction has a quieting effect on the nerves around a painful tendon, which is why many people feel a difference within minutes. This is not folklore. A randomized trial published in the British Medical Journal compared education plus exercise against a corticosteroid injection for pain on the outside of the hip. The exercise group did better at 8 weeks, and they were still doing better a full year later. Here is the protocol, and I want you to start with the seated version. Sit tall in a firm chair with your feet flat and your knees about hip width apart. Place a hand on the outside of each knee. Now press your knees outward into your hands and press your hands inward with exactly the same force so that nothing moves at all. The effort should be about 4 out of 10, never 10 out of 10. Breathe normally throughout, and count out loud if that helps you keep breathing. Hold for 10 seconds, then rest for 10 seconds. 5 holds makes 1 round, and 1 round takes under 2 minutes. Do 1 round in the morning and 1 in the evening. Over 4 to 6 weeks, build each hold from 10 seconds up to 30 seconds, adding about 5 seconds a week, and only when the week before felt easy. The chair does the safety work here, so use one with a back and keep both feet flat on the floor. Do not hold your breath, and that matters most if you take blood pressure medication, so talk to your doctor before adding any held effort. Only move to the standing version, pressing the outside of your knee gently into a wall. Once the seated version feels genuinely easy. Some soreness on the side of the hip afterwards is normal and expected. Pain that is sharper than when you started, or still worse 24 hours later, means you pushed too hard, so cut the effort in half. And night pain that increases is a signal to back off, not to push on. Now pair it with the thing almost nobody mentions. Put a pillow between your knees when you sleep on your side. Stop crossing your legs when you sit, and stop resting all your weight on one hip when you stand at the counter. The exercise loads that tendon for 2 minutes a day, and those 3 habits stop squashing it for the other 23 hours and 58 minutes. This is why I asked you at the beginning to stay until the end. The most valuable movement on this list is the one where nothing moves at all. It costs nothing. It needs no equipment, and it is often the first thing a therapist reaches for long before anyone talks about a needle. Balance is not luck. Mobility is not genetics. Independence is trained. Consider a typical case documented in the rehabilitation literature. A 74-year-old woman with 6 months of pain on the outside of her right hip. She could not sleep on that side, she could not stand at the sink long enough to wash a pan, and she had begun taking the stairs one step at a time. She had one injection, which helped for about 3 weeks before the pain came back. Her therapist did not begin with stretching and did not tell her to walk further. They began with seated isometric holds, 10 seconds at a time, 5 holds, twice a day. A pillow went between her knees at night in that very first week. The hip flexor lean and the bridge were added in week 3. Nothing else in her life changed, and she was not asked to lose weight or buy a single thing. By week 6, she was sleeping through the night on the painful side. By week 12, she was standing at the sink for a full 10 minutes and taking the stairs 1 foot after the other again. Her chair stand count went from 8 repetitions in 30 seconds up to 14. No second injection was needed. So here is what I actually want you to do. Not all of it and not perfectly. Add one piece at a time, in this order. Tonight, before you get into bed, do 1 round of the isometric hold. That is 5 presses of 10 seconds each, sitting in a chair, at 4 out of 10 effort. Then put a pillow between your knees before you sleep. Tomorrow morning, add the hip flexor lean, 10 seconds on each side, holding the counter, tailbone tucked under. By day 3, add the counter hinge and the sit to stand together, 8 hinges, then 5 slow stands with a 3-second lowering. By the end of week 1, add the bridge, 8 repetitions, 2 to 4 inches of lift on a firm bed if the floor is not safe for you, and from week 2 onward, run all 5 in order as one 90-second routine. 15 seconds of hinging, 20 seconds of leaning, 20 seconds of sit to stands, 20 seconds of bridging, and 15 seconds of holding to finish. Twice a day, and give it 6 full weeks before you judge it. Think of someone in your life who has started planning their day around their hip. A daughter or a son watching a parent take the stairs 1 step at a time. Send them this video, because 90 seconds a day is a small thing to ask and a very large thing to gain. And tell me in the comments which of these 5 you are starting tonight. Your answers decide exactly what I cover next. If this is the kind of explanation you have been looking for, subscribe to this channel. It exists to give seniors the science a 12-minute appointment never has time to cover. This video is education, not a diagnosis. Your own doctor knows your history, so bring this list to your next appointment. I'm Kenji Vance. Don't forget to subscribe and live longer.